Okay, I welcome you now to the second part of this workshop. We have fantastic speakers. The first speaker will be Valeria Santini. She will talk about Luspatercept and Imetelstat. One of the things and one of the topics which in my mind is to somehow discuss what is an early intervention. So when should we start in a given patient? So this is a question which I will give to both speakers, because if someone has a high transfusion dependency, it's clear that you should start the treatment. But what's about someone who has a hemoglobin, let's say around 10 or around 9 or around 11 and suffers from MDS and suffers from fatigue? How to treat this person, particularly when you consider the situation of the registration of the drugs. So Valeria Santini will highlight the relevance of Luspatercept and Imetelstat. Valeria is from Florence in Italy. She's president of the Italian group on myelodysplastic syndromes and is actually vice president of the Italian Society of Hematology. Valeria, please go ahead.
Thank you for the very nice introduction. So today we are going to speak about the two new or semi-new treatments that we have for lower-risk MDS patients with anemia. And what I thought was to conceive my introduction to hopefully a very lively discussion by starting with the very practical ideas. Now, first of all, we may build now a sort of algorithm of treatment of lower-risk MDS patients? Maybe yes. What is the schedule of this treatment, and what are the drugs that we may favor as first line or second line is still to be discussed. And I would really love to discuss some points with you now. So I do have a lot of backup slides, so whatever you ask me, I will try to find out in my deck of slides and explain to you, maybe, if it's not too dark. Yeah, maybe. I can also play, I can sing a little bit. I'm not so bad. So as you see here, we do have a still allogeneic stem cell transplant. I put it here because it can be still a possibility. But let's see, and let's talk about what I was asked for. So the two drugs, Imetelstat and Luspatercept. And I want to start just by saying something more about the background, the mechanism of action. The background for the Luspatercept is lying on the fact that in MDS, we have a disruption and alteration of the canonical and non-canonical TGF-beta pathway. And we do have, by that, an overactivation of SMAD3. And this is true, that is leading to transcription and early erythropoiesis block. And this is possible also, and you see, if we consider the activin receptor pathway, the same is true for this pathway that is also disrupted in MDS, but the difference being that this part of this TGF-beta family pathway is blocking in MDS because of disruption, the late erythropoiesis. So how can we intervene here? This was done, in different way. In the beginning, several years ago, there was an oral drug called galunisertib that was acting directly on TGF-beta. And this drug actually didn't have such a strong efficacy and activity. Then when the attention was moved from TGF-beta itself to the activin receptor B, you see that the ligand trap sotatercept and luspatercept showed really efficacy in increasing hemoglobin. And this was made was possible because luspatercept and sotatercept were blocking GDF11 and activin, so that the activin receptor 1b was not activated, and we could therefore restore the late erythropoiesis. I want to make it clear because the different mode of action of the drugs are very important to see how we may use it. So then we change gear. Telomere dysfunction has been known to be present in MDS, although I must say that there are not specific studies, not many specific studies. There are scarce evidence and, well, some of them very old and produced many years ago. So what we know, in fact, that there is a very complex modulation of telomeres and length in hematopoietic stem cells, and that this regulation is altered in MDS, so that we have to distinguish the dysplastic hematopoietic stem cells to the more mature progenitors. And this makes things a little bit more difficult to understand when we go to intervene in this kind of regulation. So the idea of using imetelstat, that is a specific telomerase inhibitor, was that hematopoietic stem cells in myelodysplasia have an elevated telomerase activity. Now, there are evidence, and this is why in the beginning I was also a little bit doubtful, indicating that telomere length, is decreasing and shortening in MDS. But we have to consider hematopoietic stem cells in which there is a great activity by telomerase. So imetelstat binds to telomerase, prevents the maintenance of these telomeres, and in this way we believe that is increasing the apoptosis and the elimination of dysplastic hematopoietic stem cells, allowing normal hematopoiesis to recover. Okay, so given these two mechanism of actions, you see there are not overlaps of mechanism of action. These are two completely different agents. So imetelstat on one side and luspatercept on the other. So erythroid maturation is induced by luspa. Imetelstat uses let's say, it's targeting telomerase activity in hematopoietic dysplastic cells. So I want to start from what we usually use as a closing slide. This is something that will appear, or it has already appeared, in the ASCO 2025 educational book. I'm chairing the session on educational novel treatment in MDS. So this is why I focused on anemia, because the novel treatments are only focusing on anemic patients, transfusion or non-transfusion dependent. And this is why we built this algorithm. I built it on the basis of anemia, transfusion dependent or transfusion independent. For the transfusion independent anemia, we have, in fact, the old erythropoietic stimulating agents. We do not have data at present indicating any activity, not yet, because we are waiting for the results of study, of the new drugs. So we go the old way. And we will use the new drugs only in second line, that is when ESA response is lost, and we need to have a second line treatment. So transfusion dependence after ESA requires intervention with lenalidomide for the patients who are MDS del5Q, and with different approach in patients who are ring sideroblast positive or negative. Now, in this area, I suggested for the negative still imetelstat, and for positive luspatercept. Luspatercept is active also in RS negative. the activity is more or less the same. There was a lot of discussion on this point, but this is what is coming straightforward in all countries. You may use it immediately. It's transfusion dependency, RS positive, you go for Luspa. And Imetelstat, as you know, is not readily available for many countries. So for RS negative, we can also use Luspa. And then we have here transfusion-dependent del(5q). They come with you, to your office, with already need for transfusion. If they are MDS del(5q), you give lenalidomide. Otherwise, you go for Luspa, whatever is the ring sideroblast condition. And then what happens when they lose response to lenalidomide? Unfortunately, we have nothing in the moment. There have been few cases treated with luspatercept. Only, I think, a couple responded a little bit. After Luspa, we may have, you see, either an off-label lenalidomide. I led a study 10 years ago in which there was some response after loss of response to ISA. There are no data now after losing response to Luspa. There are some evidence, if you want, I can show you, that imetelstat can still work in these cases. But again, there are other options that we should always consider. So you see, here we have some data that are indicating us the possibility to choose for the best for our patients. And I also did something similar, you see, for the patients, anemic patient, non-del(5q) transfusion dependent. This is another publication that you'll see very soon. And the idea is the same. When you have, this is, I went into details. When a serum EPO is very high, so you are not really eligible for ESAs, you should go immediately to luspatercept. When the EPO levels are lower and you have very low transfusion need, you can try the ESAs. But otherwise, if you have transfusion need that is in between 2 and 4 units in the 8 weeks, for sure you should go for luspatercept. And then if you have more than 4 units, you may still consider luspatercept, taking into account that if the units of transfused red blood cell are above 6, the response can be low. And otherwise, you can consider imetelstat that is working quite well in patients who have more than 6 units of red transfusion, so red blood cell transfusion. So you see that there are some subtle difference in these two algorithms that I'm going to present at the same time. But basically, what is leading you is, first of all, consideration of transfusion dependence. And then after that, the type of MDS and the evidence we have of the activity of these drugs. So I want, again, I'm doing the other way around. So I'm starting with dosing and safety with luspatercept. Luspatercept is a very safe drug. It's an agent that is not really giving any worries in terms of side effect. What I really want to stress is that the initial dose of 1 milligram per kilogram sub-Q every 3 weeks may not be enough. So if patients do not respond immediately, you should go on with the titration of the dose of the drug and do 1.33 and then 1.75, because some patients will respond only with higher doses of luspatercept, especially if they start with particularly low levels of hemoglobin. But then you can go back to the lower dose once you have reached the response. And the response, as we can see later, it is very long indeed. What is the main worry here? I wouldn't call it a main problem, but if you have a patient who has severe hypertension, then you should monitor the patient carefully, because the increase of the hemoglobin levels may account for worsening of blood pressure. Dosing and safety of Imetelstat. So we start with an IV dose of 7.1 given in 2 hours. This is a drug that is given IV and needs premedication, although I never had really infusion reactions. So you give diphenhydramine and corticosteroids. And here is the opposite. If you do not see an increase of hemoglobin or stop of transfusion, you should continue treatment, but you cannot increase the dose. On the other hand, if you see myelosuppressive effect, which is seen, especially thrombocytopenia and neutropenia, you should delay the treatment, that is IV every 4 weeks, or lower the dose and let the patient recover the normal counts. So there is another important point. You have seen the graph that I tried to design to show you the mechanism of action of luspatercept. And you saw that the target is removing the block to late erythropoiesis. So late erythropoiesis is restored by treatment with luspatercept. But so the target cell for luspatercept is not the same as for ESAs. So ESAs can be used logically as a background together with luspatercept because ESAs are targeting and they have receptor on CD71 erythroid progenitors, and they would stimulate these progenitors. We may discuss here whether ESAs are stimulating normal cells or dysplastic cells, but this is the point is that they promote early erythropoiesis. So together, the two drugs may indeed have a synergistic effect, and this is the way we would like to go. So combine the two drugs, and in fact, there is a French group study, the MDS French group is extending it to EMSCO, to the European MDS group, is promoting this study, combining ESAs with luspatercept, this time in non-ring sideroblast positive MDS. Now, these are data of some months ago, so 24 patients, luspatercept given every 3 weeks. The same dose, starting a little bit lower, 0.8 to 1.75, and EPO alpha to the concentrations, the optimal concentration that you know. And then the final design of the study that is now extended and open to other centers is the highest dose of Luspa plus EPO 65,000 unit a week, to see whether we can really increase the response in the non-RS MDS, the ones that if you remember my first algorithm, I said, well, maybe they can still be treated differently. So this study that is called Combola will really show us whether the background of the mechanism of action and biology of MDS can really support this combined use. Now, as we were discussing, we are now tempted to treat earlier and earlier our patients. So why should we wait for transfusion dependence? We do not wait for transfusion dependence to treat with ESAs. Why should we do it with luspatercept? And this study, the Element MDS study, is comparing luspatercept to EPO in non-transfusion dependent patients. And of course, the endpoints are of course, the time to transfusion dependence. And as you see, the increase in hemoglobin more than 1 gram deciliter plus transfusion independence longer than 16 weeks. So this is still ongoing, so we cannot really respond to this question, but I think it's going to be an interesting approach. As well, I don't have it here because I was not supposed to speak about LEN, the approach of the Spanish group in which they demonstrated that the time to transfusion dependence with lenalidomide in non-transfusion dependent del(5q) is very much decreased by early treatment. So I don't know if I stop here, if I go on. As I told you, I have a lot of slides, so it depends on the reactions and questions, and I can choose to respond with or without slides. Thank you.
Thank you. Valeria, please, please stay there. I think it's now a good time to stop. Maybe we have more light in the room, in the audience. Could you go back to the algorithms? I think these are quite instructive. Yes, the next one?
Yes.
So is this one which is now in publication? Or?
Yes, both of them.
Both of them? What is the difference between the first one and the second one?
No, in the first one I added also the thrombocytopenia, then I eliminated it because it was confounding. But more or less I had more options here in the first one than in the second one. Here I was trying to be a little bit more straightforward in what we should do for our patients.
I have realized that the thresholds for erythropoietin levels have changed a little bit, sometimes 200, sometimes
yes,
500.
because in Europe, yes.
Could you argue about this?
In Europe, EPO is approved for treatment of patients who have less than 200 units liter, serum EPO. Whereas in other countries, there is not such a threshold, and there is still the old Nordic country evaluation of 500. Having said so, I also have to add that you rarely, very rarely, see patients who have such high levels of EPO. Usually serum EPO is not so high. It's higher, of course, than expected. It's very rare that it's over 500. And what I always doubt when I see 700 units liter of serum EPO is that, in fact, it's not an MDS, but it's more a pure red cell aplasia, in which EPO level is very, very high usually.
Yes, one question from the audience.
Hi there, Valeria. Lynette Chi from Australia. Very nice talk as always. I noticed that with your lower-risk MDS, your scores there is an IPSS-R of less than 4.5. But there are some other publications who have classified lower-risk MDS as under 3.5 because the intermediate risk is a very heterogeneous group.
It is.
Between 3 to 4.5. So do you get a bit more worried if they sit on the higher part of the intermediate risk? And would you then recommend that they go into a clinical trial or have HMA-based treatment?
Okay, that's a very good question. Thank you. In fact, intermediate risk MDS, as you know, are very frequently included in the low-risk treatment trials. Some rarely, and anyway, we don't have good options for high risk, are included in the high risk. Now, the clue, and to answer your question, is to use the IPSS-M, because this could help us. Now, given the fact that now we do not have studies in this sense, and that still the rapid availability of NGS data is not really open to everybody, I stick to that. Now, of course, patients who have a higher, so the intermediate level IPSS-R, are the ones who very frequently respond less. The HMA trials have been done in the past. We have led the oral azacitidine trial many years ago together with Guillermo Garcia-Manero. And again, it depends on how you determine intermediate, because some of these patients may really be higher risk, disguised higher risk. And therefore, treatment with these agents can be tricky and can lead to failure. So I think that we have to be a little bit more subtle to optimize treatment. That's for sure. HMAs can be interesting, but they are myelosuppressive, as you know, and therefore they should be used with caution. And again, if the patient is low risk or intermediate and has a lot of mutations, maybe you should be a little more aggressive.
Thank
I don't know if I answer your question.
Hege Garelius.
I was wondering about this non-del5Q transfusion dependent. There is a clear difference between the European approach and the American approach because they include lenalidomide. Can you comment on that?
Yes. Thank you for this comment. So lenalidomide is not approved anywhere for non-del5Q, and it has been used in the US very frequently as off-label because there was no alternative, and non-del5Q transfusion-dependent patients are really the majority of patients, and they usually are increasing and progressively increasing their transfusion need. Having said so, as I mentioned, in 2015 I published the data of an international trial in which it was clear that lenalidomide could induce good transfusion dependence and good response in 42% of patients if you were selecting them, non-del5Q of course, on the basis of the serum EPO level at the moment of relapse after ESAS. But as far as I know, there are good experience, but as I mentioned, they're all off-label.
Yes, Inga. Inga.
Hi, everyone. A great presentation. My name is Inga Mandac. I come from Croatia, Zagreb Clinical Hospital.
I know you.
Hi. Well, if I want to convince my health insurance companies about the approval of new drugs in MDS, like Luspatercept, Imetelstat and stuff, they're not very good to the patients, and they're not very friendly with hematologists. And I have to convince them that this drug is really great, and the priority for this group of patients is to be as low as transfusion dependent as possible, or the better, transfusion independent. But when they see our guidelines, and the update of guidelines will be next week in Croatia in one of our symposiums, I have to say, well, if the patient falls or is coming to 100 gram per liter of hemoglobin or 95 gram per liter, I think we should intervene with the new treatment. But if they see the hemoglobin higher than 80 or lower than 100, I'm not very sure that they will be, or my even hematologist will be happy with that. What threshold of hemoglobin will you give if you can choose one number and say, well, maybe we should take 100 or 95? Or what anemia symptoms will you consider that I have to explain them that patient feels, because this element MDS put 4 of them. I think fatigue, loss of, these are 4, and they said if the patient doesn't have 95 gram per liter, he had to have one of these 4 anemia symptoms. And the other question is, did you, in your studies or your experience with Luspatercept, noticed any difference between response considering the cellularity of bone marrow? Because some data said that patients who have hypercellular bone marrow respond better with Luspatercept compared to these hypo or normocellular. Thank you.
Okay, so for the last question, I didn't really see great difference, but I also didn't see many hypocellular bone marrow patients treated only with Luspatercept. And again, then you have to, well, we can discuss a lot about hypocellular MDS. It it is defined on the basis of age as well, and many of them respond pretty well to immune suppression. So this is a category of MDS that is really specific and different. Whereas for Luspatercept, I really had a very good experience also in patients who didn't have a super full typical RS marrow. Regarding the other question that is more articulated, I would say that I change gear and I change the drug if the patient does not increase at all the levels of hemoglobin. So if the patient has lost response to ESAs and has transfusion dependence, I start Luspatercept. If Luspatercept is not increasing hemoglobin in the way to render the patient transfusion independent, and I measure it only increasing the dose of the drug to the maximum and waiting for at least 6 months. If this does not happen, but I can tell you that there are patients who are responding later, then I change the approach. But I base everything, at this moment, you can base it only on transfusion dependence, because these drugs are all approved only for transfusion dependent. So you have ESAs, and you can start when patients are non-transfusion dependent, like here. Then when they fail and are transfusion dependent, here, this is what you do. But it's only, so it's not a level of hemoglobin, it's a level of, it's the transfusion dependence that is driving us at present. Maybe in the future will be the level of hemoglobin, but not now. And again, the element study is setting a new future, but is not yet there. What we do for ESAs, at least in my country, when a patient has hemoglobin level around 10 or less than 10 and symptomatic, and they ask for help, of course, because some people are completely asymptomatic, then we start ESAs.
We are all not completely satisfied with the situation where transfusion dependency and overall survival define the criteria of registration. I mean, that was also mentioned today by Eva. So in the future, we will try to define, let's say, changes in quality of life or changes in functional activities as parameters for treatment start and for registration of drugs. But now I think we should continue. Valeria, thanks a lot. Last. No, I go there. You go there. Last but not least, we have Moshe Mittelman from Israel. He has so many functions. He's actually Professor Emeritus at the Medicine and Hematology School of Medicine, Tel Aviv University. He has established a hematology oncology service in the Oncology Center in Kiev, Ukraine. His research interest includes basically in clinical aspects of stem cell disorders, which include myelodysplastic syndromes and MPN, basic and clinical effects of erythropoietin, and he's working on translational research of malignant hematology, and he's interested in applying digitalization into practical medicine, an important point. Moshe will give an overview on treatment guidelines, and I think he will try to somehow summarize from a clinical aspect different treatment options which we have in low-risk MDS patients. Moshe,
thank you,
please.
Reinhard. You can go on.
No, now it's your go.
I wish my wife had been here and she would have believed all that you have. So thank you, Reinhard, Valeria, dear friends. I apologize that I have to start with 2 disclosures. Number one, probably I'm not going to tell you anything new that you have not heard or read. The second one, when Aryan and Saskia, the organizer, approached me they asked to talk about low-risk MDS, and I said, okay, I can talk about low-risk MDS, but then when I saw the title, I saw a critical review, and in fact, I'm part of the group of the guidelines, so how can I criticize the group that I'm part of? So I have a personal problem, and I hope you will help me, but what I decided to do, frankly, is to give kind of a summary for a clinician, summarizing the pros and the cons of each treatment. And probably it will give you some clues in the daily and weekly sessions, as well as Inga with the regulators. When you argue with them, you can show them only the first part of the pros, don't show them the cons, okay? So these are my other disclosures. And I guess we can skip this slide that every hematologist dealing with MDS would like to start with, but I think we can. And what am I going to talk? I'm going to talk about transfusions, ESA, lenalidomide, luspatercept, imetelstat, treatment for thrombocytopenia, treatment for iron overload, but I'm not going to describe everything. I'm just going to focus on the pros and the cons of each treatment. So let's talk about transfusions, the oldest, but still very, very popular all over the world. So the advantages, as we all know, immediate relief of symptoms. Sometimes it's life-saving, immediate life-saving, especially if patients suffer from congestive heart failure, if patients require surgery. It improves the organ function because the oxygen delivery is getting better to the organs, increases the hemoglobin level, reduces the transfusion requirements, obviously improve quality of life. It's relatively easy, available globally, well-established standard procedures, and here you can see the picture of Rina Buckstein and Simon Stansford, two of the pioneers studying this. Interestingly, relatively very few studies really touched this topic. But on the other hand, one has to take into consideration that we are not treating the underlying disease. The effect is pretty short. Indeed, it stimulates and leads to iron overload, which we all believe today that it's toxic, despite the controversy. Sometimes it is associated with reactions, acute as well as delayed. We all know it. We, as well as others, have shown that it stimulates alloimmunization with antibodies, transmission of infections. Sometimes it impairs quality of life, requires a system with typing, matching, mismatch sometimes with problems, infusion, everything, so it has to be in a center that is recognized and can do it. And the point of disease progression, indeed, is still controversial after so many years. So in summary, as for red blood cell transfusions, indeed, it is immediate solution for urgent anemia. It improves quality of life and organ function, but on the other hand, don't forget it does not address the problem. We mentioned the significant limitations, and the conclusion is that immediate supportive measure, yes, but yes, we should consider other measurements. You can see here the picture of Louis de Swart and Theo de Witte, who also studied these aspects. Now let's go for ESA. As we all know, that now has been with us for almost 3 decades. The advantages are also clear, and I think Valeria has also emphasized this. I will just go very briefly. It increases the hemoglobin level, it reduces transfusion needs, and by the way, by the question that Valeria, you were asked, I know that FDA and other regulators are more interested in transfusion needs and symptoms and less in numbers, such as hemoglobin threshold. It delays the need for transfusion, it improves quality of life, it may avoid the complications associated with transfusions, but what about prolonged survival? it is possible, and only recently, Hege Garelius, Eva Hellstrom, and others, we in the European group published a paper in Lancet Hematology, I think, Hege, it was last month, and we showed, indeed, life prolongation, but we have to admit it was a retrospective study. It can be given as an outpatient administration. It can be relatively long duration, about 2 years, and possible also some clues also from my group that it might have also anti-neoplastic effects. But on the other hand, one has to take into consideration the limited efficacy. The response rate is probably 50, 60%, maybe even less. The factors that depends are the serum EPO. Valeria has touched it in more details. The transfusion burdens may be a problem, also one of the factors. There is a question of disease progression, probably more in the solid tumors, not in MDS, but I have to admit that whenever I'm talking about it with colleagues and patients, someone raises the question, what about disease progression? And it is a serious question. Some side effects, which I don't have to tell you, and the need for monitoring, still expensive in many countries, and also kind of a bone damage that has been shown by my group and others that might be related to ESA. So again, there are pros, there are cons. What about Luspatercept? And I'm trying not to overlap and repeat what Valeria has already explained. Now, I don't have to tell you that it's quite effective, and I don't have to repeat that the commands probably try to convince us that this is the first line now. And you can see here Pierre Fenou and Uwe Platzbecker and Amer Zidane, and your picture, Valeria, will come later. And the disease is, the duration is indeed durable. The mechanism is different, as Valeria explained, and definitely can be an advantage on ESA or patients who are resistant to ESA. It's probably more beneficial in RS, although we heard that patients with no RS can respond as well. It's convenient. It's convenient because the injection can be given only every 3 weeks, very convenient to our patients. They are coming every several weeks, so it's very convenient. Is it prolonging the survival? There are some clues, but not a proof yet. On the other hand, there are some limitations. The side effects, I know, Valeria, you said no side effects. Here and there, I had patients telling me, listen, doctor, if you have other agents, I would prefer them. So there are some side effects. The response rate is around 50%, maybe even less. It's not effective in all subtypes, but we discussed it. There is some risk of extramedullary hematopoiesis, although more in thalassemia, not exactly in MDS, but this is something that we cannot exclude. Require monitoring. It is expensive in many countries, including, unfortunately, my country. It has not been approved yet by the public authorities. Patients have either to buy it or to use their own private insurance. What are the long-term effects? We still don't know. You can see here Mateo de la Porta and Guillermo Garcia Manero. What about lenalidomide? Also discussed in details by Valeria, but I'll touch the pros and the cons. There are some definitely advantages to lenalidomide. The erythroid response, especially in del(5q. Alan List was the first one, probably in the 2003 or 4, I think, in New England, to demonstrate the effect in del(5q, also in non-del(5q, but more in del(5q. There is also cytogenetic response, as Pierre Fenou, and we showed it in the MDS 004 paper, improves quality of life, relatively well tolerated, oral administration, which makes it easy. There is potential synergism with other agents, especially ESA, because of the different mechanism. There is a potential for disease modification, again, questionable, not really proven. And it might delay the transfusions, as also Dr. Santini mentioned, and recently demonstrated by Maria Diaz Campello by the Spanish group, published in Lancet Hematology a few months ago. But there are some limitations, and you, Valeria, also showed some of them. It is not effective in all. In the non-del(5q, your paper from 2016, we talked about 27% no more in non-del(5q. Maybe if you select them better, you can achieve higher response, but still many non-del(5q patients are not candidate for this approach. There are some side effects. I had a patient who told me that he has to maintain 2 pens in the office because of the diarrhea that he cannot control because of the lenalidomide. So sometimes it might be a problem. The disease progression to AML, probably this is not the case, but it was suggested, and we were arguing about that about 10 years ago. The duration of effect is less than 2 years. And there is probably a clonal evolution, especially of the TP53 in some patients treated with lenalidomide, and we have to take it into consideration. Obviously teratogenic, but it's not really a practical problem in most of our patients, and yes, there is a cost for that. What about imetelstat? There are some advantages. This is David Stinsma, who probably was the first to show it in 2017 or 18. It's convenient when you can give a shot only or infusion every 4 weeks. The duration appears to be long. There is probably potential modification of the disease because the VAF has been shown to decrease. It's effective in many subtypes of MDS. So far, no any bad effect on survival, but it's relatively new. On the other hand, we have to take into consideration again the limited response rate, less than 50%, the need for intravenous infusion. It's not a big problem, but sometimes it's a limitation. The side effects, other side effects, liver, fatigue, and others. And again, the cost, which we may avoid it because of this problem. What about platelet transfusions? Platelet transfusions are the rapid way to increase the platelet count, to prepare patients to surgery, and to avoid bleeding. And we all use it. It can be treatment as well as prophylactic. It allows necessary procedures, surgical and so on. It might improve quality of life, and it is relatively available in most centers. On the other hand, one has to take into consideration that, again, as transfusion, we don't address the cause. The effect is very temporary, very transient. Some patients, it may last less than 1 day. There is always the transfusion reactions, again, alloimmunization, which makes the next transfusion even more difficult. And all of us are familiar with the bad conversations and the bad phone calls from the blood bank. Hey, are you sure that you need this platelet transfusion? Because I have difficulties transmitting infections. And the cost sometimes may be a burden. And it has been also shown, although it's rare, that sometimes it may cause thrombotic complications. What about thrombomimetics? It's clear that thrombomimetics can increase the platelet count, again, in about 40 to 50% of the patients with thrombocytopenia in MDS. It has been shown initially by Chagob Kantarjan in 2010 or 2011. And it can increase the platelet count. Esther Oliva from Italy also showed a very nice paper in Lancet Hematology 2017. Longer effect, convenient administration. There are 2 agents, promiplostim and L-thrombopag, The data are very similar in both of them. It can improve quality of life. It allows other MDS therapy because if the platelet count is increased, then you may be more liberal with other treatments, especially for the high risk, but also for the low risk. And if you take L-Thrombopag, it's even oral, which makes it very easy and convenient. However, on the other hand, the response rate again is less than 50%, probably closer to 40%. There are some side effects related to both agents, Romiplastim and L-Thrombopag. It has been even, and probably the most important problem, it has been suggested by several papers that both of them may increase the number and percentage of blasts. Although it has been later on shown, and I myself also wrote an editorial about it, I think that these fears are kind of exaggeration, and I'm not sure that this is really that dangerous. However, we have to admit that the development has been stopped because of this problem. And right now, unfortunately, our patients with MDS and thrombocytopenia do not have any effective agent to increase their platelet count, and I think that this is a shame. And we as community have to do something about that. Just last week, actually just last 3 days, I visited one of my patients with 10,000 platelet count and MDS who was admitted because of intracranial bleeding. And this is a patient who I could give her several times L-Thrombopag or Romiplastim, but I could not because it's not approved. So we have a problem with this. What about ion chelation? Well, ion chelation has been with us for a long time, but we have to admit, and the Italian group has done a lot about it, and others also, we have not been able so far to convince enough neither the authorities nor the patients to take and to use ion chelation therapy in the numbers that we need, that we believe they need them. We have, as we know, 3 agents. We have the deferipron, L1, we have the desferal, and we have the XJ, deferasirox. Now, the advantages are probably clear and well known to all of us because we believe that ion overload is toxic, and we know that we can chelate ion and we can minimize the risk. There is enough data to show that decreasing ion also improves erythropoiesis and improves some of the hematological parameters, and that might by that decrease the need for transfusions. It potentially improves survival, although it has not been shown exactly. There is a potential that it probably reduces the risk of disease progression, but again, it's not clear-cut proven. And it has been shown that it improves the outcome of transplanted patients. The limitations, on the other hand, unfortunately, so far, despite all these years, the only one prospective trial that has been published in Annals of Internal Medicine in 2020 or 2021, Emanuele Angelucci was the first author. This is the only one prospective which was able to show advantage in terms of event-free survival, but not really overall survival. But we have to admit that we believe that indeed it's effective. But there are some side effects, and the side effects are sort of different from all the 3 drugs. There is the burden of therapy, especially the desferal. Not every patient is ready, and we in the MDS community are not that successful as the pediatricians taking care of the patients with thalassemia who can be treated with a pump of desferal. The treatment is still expensive, and there is some uncertainty regarding the optimal plan. So yes, it's not easy to use these ion chelating agents. So in summary, and as I was requested, I will leave some time for Q&A. If one is summarizing all these treatments for MDS, for low-risk MDS, there are some considerations that you guys as clinicians, with the patients, with the regulators, have to take into consideration. And as I said, feel free to use some of them, all of them, or none of them. There is always the risk assessment, the problem, the anemia, the thrombocytopenia, the iron overload. We can always consider and balance between the efficacy and the side effects and the potential complications related to the treatment. We have to take into consideration the comorbidities, the life expectancy, the availability, what is approved and what is not, what coverage the patient has to add or what is covered by the health insurance company. Obviously, in 2025, we might or we need to individualize the treatment and to consider the patient's preference. I guess we all discuss with our patients each treatment, the pros and the cons, and when we have the opportunity to choose, we can choose the one that is more suitable to the patient. Quality of life, fortunately, are becoming more and more important, at least in patients with lower risk, and I can say that it's not like 10 or 15 years ago. It's more and more important for the patients as well as for us, and we can see it also in many trials that it is one of the parameters that is being tested. And in fact, our chairman, Reinhard Stauder, is one of the pioneers of testing the quality of life and also responsible for the paper of the EU MDS group in leukemia, 2018, I believe it was this paper. And yes, requiring monitoring for all the treatments that we are providing. So I talked about cost and cost, so there is a problem of financial toxicity, and you can see that this happened to one of my patients who went to the pharmacy. The pharmacist told him that there are no side effects, but the price can make him dizzy. And this is it. I left a few minutes for discussions of pros and cons, agreement and disagreements.
Thank you very much for this critical review. I assume there are comments, questions.
Thank you. I'm Astrid Olsnes from Bergen, Norway. Great presentation, very interesting. I was wondering about that TPO agonist treatment, because you said you were not giving it to your patient, even though it sounded like you really believe he should have gotten that treatment. And we know that MDS is associated in maybe 30% of cases with autoimmune manifestations. So do you have any strategy or tips? How can we distinguish the patients that probably have sort of ITP-ish thrombocytopenia that we could give TPO agonists to safely?
Yes, thank you for this question, because I think it is a very, very practical and important question. I'll tell you a secret just between us, don't tell it to anybody, that if I can say that my patient has ITP, I give it, okay? But don't tell it to anybody. But the reality is that we have a real problem with our thrombocytopenic patients with MDS. Now let's evaluate for 2 minutes really the data, okay? There are about 8-9 papers in general talking about both agents, and in fact there were only 2 or 3 that showed increased number of blasts. And also, if you take the Hagob-Kantarjian long-term effect published in 2018 either in British or Lancet Hematology, I cannot remember at the moment, he showed that after 5 years, probably, it was not the case. So I feel that at least in the lower risk, we can still argue about high-risk MDS patients. I feel that giving L-Thrombopag or Romiplastim to lower risk patients, it is safe. There is also a French study. The first author was Comment, showing also that late follow-up after these patients was pretty safe. So at least, in my opinion, low-risk patients with thrombocytopenia can receive thrombomimetic agents. Unfortunately, it is not approved, and unfortunately, the development has been stopped. I am opening parentheses and saying that tomorrow we are going to have a special session on development of drugs for MDS, and I think one of the points that we might stimulate and discuss is why some companies decide to stop development of treatments even when we as physicians think that it's not the case and they can continue to develop it, okay? But now I'm coming back to the question. So the data are there, 2-3 papers which showed increased number of blasts, 7-8 papers that could not support it, and on the contrary, they showed confidence. Unfortunately, no approval, unfortunately, stopping the development. What do I do in practice? If my patient has isolated thrombocytopenia, which I can see that it is ITP, I am trying to give them L-thrombopag or romiplostim. I did not see any problem since then. Although it's not evidence-based, it's not controlled trial, but this is what I do. If the patient has more like standard classical MDS with neutropenia, anemia, I have a problem and I cannot get it because it is not approved like in the patient which I mentioned, and I think it's a problem. We don't have solution for these patients, yes.
Thank you.
Okay, thank you very much, Moshe. Okay, then I will end this session. I think it was a lively discussion. It was a very constructive discussion. We have realized the chances, but also the challenges in low-risk MDS. I talked to thanks to the audience and thanks to the presenters, and wish you a nice and fruitful further Congress here in Rotterdam. Thank you very much. Bye-bye.